Well, thank you ever so much for having me. The opportunity to talk about MIE for an hour is always gratefully received. So I am going to talk today about the usage of MIE outside of a neuromuscular population. And what I'd specifically like to think about is airway clearance outside of neuromuscular. What is it that's different? And what is it that MIE does or could add to this patient group? And then we will obviously look at the evidence, see what it says with regards to what conditions are being treated and managed with the device, how the device is being used, and also the outcomes that are being measured. But I think more importantly, what we need to be thinking about is what we actually don't know about this device, and that's where we'll finish. So we'll open the can of worms and then we can all go and have some lunch. So just to really recap, we all know the components of a cough, but is the components of a cough any different outside of neuromuscular? No. We need to have that really big breath in to kind of 85–90% of total lung capacity. We then have the compression phase where your glottis will shut for like that 0.2 of a second to really increase those pressures, those intrathoracic pressures. So then when the glottis reopens, you have this lovely expulsion phase, and then hopefully the sputum is cleared. Mechanical insufflation, exflation, as we know, or MIE, is a non-invasive device used to augment cough, and it delivers, first of all, this positive pressure breath to give a patient a really lovely big breath in, and then that rapidly switches to a negative pressure breath to suck that air out again. And it's this quick switch from a positive to a negative pressure that really simulates a patient's cough and then hopefully clears airways of secretions. Now, we know that this device is used a lot in a neuromuscular population, and that's where the evidence predominantly lies. But for sure, we know that this device has started to be translated into other patient groups, and that's obviously what we're going to look at now. So obviously in preparation for this talk, I did a lit search just to make sure I did know what I was going to talk about. And I literally on PubMed put in mechanical insufflation, exsufflation. For the last 10 years, I generated just 143 papers, so not actually that many. And once I'd got rid of all of the neuromusculars, so the ALSs, the Duchenne's, and then also some of the spinal papers, acute and chronic, I wasn't left with that many. Quite a group of them were ICU related. And then I was left with these five that are quite different, 5 that are all in very different patient groups. So you've got the top one, which looked at a single patient with non-TB mycobacterial disease who was also very frail, had a pneumonia, so they used MIE, and surprisingly enough, he's ended up with a bilateral pneumothoraces. There's a randomised controlled trial of patients with pneumonia that compares MIE to the use of CPAP and oxygen. Some cardiac surgery patients, a case study again in the cystic fibrosis patient, and then also a study combining this electrical stimulation to MIE to see if that enhances its utilisation and effectiveness. So some interesting papers, don't get me wrong, but certainly not enough to base a 45-minute presentation on. So what we're going to look at is actually the intensive care population, because this is where the next kind of, after neuromuscular, this is where the next bulk of literature lies for sure. And what we can't forget is that ICU is purely a location. It's only telling you where the patient is in the hospital. The cohort within it varies dramatically. So yes, we know they're in multi-organ failure. We don't necessarily know how else to describe them. So if we think about the ICU patient, we know that they're critically ill. We know that they're already therefore working really quite hard, systemically especially. Most of these patients are going to be on some form of positive pressure ventilation. And we know from previous studies that those repeated positive pressure breaths actually do act to further embed sputum into the lungs. We know because of the medication, the sedation that we're giving them, their cough will either be absent or at least a depressed cough reflex. And we know in ICU that mucociliary clearance rate is also further reduced. The kind of impact of an ICU sleepover and ICU weakness is very well documented. There's extensive literature on that, but it's not just your arms and legs that are impacted, your respiratory muscles also are too. So obviously the cough is impacted. So all of these factors, alongside the use of that artificial airway, keeping open your glottis, it's not surprisingly we end up with a reduced cough strength and efficiency for sure. So actually then when we go back to the cough components, and we're going to see these patients on ICU who need to have their airways cleared, we need to be having extubation success, not extubation failure. Once somebody is extubated and it's starting to fail, most likely that is due to retained secretions or poor cough effectiveness. And we know that once somebody fails their first trial of extubation, they are more likely to fail another trial as well. And their mortality will increase fourfold, as will their morbidity, their quality of life also reducing. So it kind of really shows how important it is to really try and clear somebody's chest. And we have loads of strategies to do this on ICU for sure. We're not going to go through all of them now. We're focusing obviously on the mechanical insufflation, exsufflation. So what does the evidence actually say? This is one of the early papers for sure. It's from 2012, Gongal's paper. And here they randomised 75 patients who all had hypoxemic respiratory failure with or without hypercapnic respiratory failure, and all of which had passed a spontaneous breathing trial, which in the paper is really well described. So the patient cohort within that 75 patients were COPD exacerbations, heart failure, community or hospital acquired pneumonia, post-operative respiratory failure, and also cardiac arrest patients. So as I say, patients were randomised to either control arm, which was just standard care, or this mechanical insufflation exsufflation protocol, which involved treatment either in the 24 hours prior to extubation or the 48 hours afterwards. So a kind of a 3-day study period in total. And it was a protocolized MIE setup, as you can see, with abdominal thrusts on exsufflation, and reintubation rates were their primary endpoint. So as you can see here from the results, they are really, really positive results. The primary endpoint being reintubation rates, that was significantly lower in the MIE intervention group. The use of non-invasive ventilation following extubation again was lower in the MIE treatment group, with NIV failure for all those that used it also being lower in the MIE treatment arm. And also that post-extubation ICU length of stay was also shorter. And that's important when you think of the cost of an ICU sleepover. It's way more expensive in comparison to a more high dependency level bed or even a ward-based care. And so these are things that we need to think about as well as flow through the hospital. So moving to a slightly more recent study, this is from 2018, the Ferreira de Camille's paper, and here they randomised patients again to either standard care versus mechanical insufflation exsufflation. Patients here had been on the ventilator for just 24 hours and they were labelled as being stable, which meant for their definitions they were on a PEEP of either 8 or below, and then a fraction of oxygen, inspired oxygen, of 40%, again or below. So there was 180 patients in total, so a really lovely group size. And they found basically in the MIE arm that there was an increased aspirated airway clearance, airway mucus clearance in the MIE treatment group. So really, really positive. They did also find an increase in compliance in the MIE treatment arm, which we'll come back to later on. This group performed a subgroup analysis, which showed that actually when you were older than 65 and also didn't have COPD, that's where most of the benefits from MIE came. So that's quite useful from an applicability perspective. But actually this group didn't look at some really important outcome measures such as survival, duration of mechanical ventilation, and there weren't really many clinical variables looked at either. So this is interesting because the protocol itself was quite different. The standard care was compressions, vibrations in alternate side lie, some mechanical manual hyperinflation, MHI, then a pause for about 5 minutes and then suction. And same in the MIE group, the MIE protocol was completed, there was a 5-minute pause and then suction. So yes, we've got positive results with this for sure, but actually clinically, when do we ever do our treatment, wait 5 minutes and then do a suction? We tend to do it in parallel with the treatments that we're doing, or at least especially when we see the sputum being cleared. So I think it's something to think about, and it would be interesting that if the timing of suction was changed, whether the results would be slightly different too. So this only came out last year, the Martinez paper. And here, again, it's patients who were on the ventilator for 48 hours or more, just 26 patients. And again, that mix of patients being acute respiratory failure, cardiac arrest, or brain or abdominal surgery actually were also included. And here they looked at the use of expiratory rib cage compressions with or without mechanical insufflation exsufflation. Patients were randomised to either group. They had their treatments, there was a 4-hour washout period, and then they switched to the other group. So it's a crossover trial. And again, some really positive results. So here we have a total of 430 MIE cycles from a data perspective. That's an awful lot of MIE cycles. And what they found was that there was increased sputum clearance with those expiratory ribcage compressions with MIE. The compliance again increased in both groups, but more so in the MIE. And then there was an increase in oxygen saturations, even still at 1 hour in the MIE intervention group. A slight increase in heart rate in both of the groups, but these seem to be transient, so nothing concerning. So let's just have a look at these results and just think about them a little bit more. Excuse me. So you've got sputum clearance, so that's good. But almost how has that happened? What is it about the setup that's created this expiratory flow bias? We've got a symmetrical pressure setting here, so 40-40. So that by itself certainly won't be enhancing expiratory flow. But actually the flow of the device was set to medium, so that could be helping. We've slowed that insufflation breath down, so that could be quite positive and have a positive impact. We know that from the Volpe bench studies. But also it's done in combination with these expiratory rib cage compressions, which the purpose of which are to increase your expiratory flow bias. So maybe that's what helped. So you've got to think about these things too. From a compliance perspective, compliance increased in both groups, so that's positive, but only really lasted to the hour. At the hour point, there weren't any differences. So what are the sustained effects of MIE? This is almost similar to what we know as the BIRD in the UK, the intermittent positive pressure ventilation. We know it works at the time, but actually the results and the impact of it don't last overly long. So actually, could we have enhanced the impact of the MIE and enhanced the effects, prolonged the effects by maybe recruiting after the treatment? We don't know whether that was done or not. And actually in this protocol specifically, we need to consider the impact of suctioning. This paper used open suction, so they've obviously disconnected the circuit, lost any pressure within that system. Whereas I know from the UK, we tend to use closed suction to keep that circuit all enclosed to maintain those pressures, which is really important to think about. And then moving on, we've got this increase in oxygen saturations even at the hour point, and so that's really positive. So you've got you've got an increase in your, well, hopefully you've got an increase in your VQs. That's really positive. And so we hope, therefore, and you can propose that the pressures have really helped open up areas of atelectasis, optimize that VQ, thereby reducing shunt, thereby increasing your oxygen saturations. It's a theory. We don't know if that's happening, but it's possible. And then, as I say, these heart rate increased in both groups, so with and without MIE. So we can't say the increase in heart rate was definitely down to MIE, but also it was a transient change. So we need to think about that. So the authors concluded that it's a useful technique. It can be effective in clearing secretions, and also that it's safe, and that's important. So with all of this evidence, we now need to move into different types of study. It's not always all about these randomized controlled trials. So this is a lovely paper, I think. It's just a case study, but actually it's talking about the use of mechanical insufflation exsufflation in an intubated population and a COVID-19 patient. It's a single patient case study. I really like this paper. It really goes through the treatment options, helps describe, and almost you're reading the clinician's clinical reasoning. So I'd certainly recommend reading it. But let's just think about it in slightly more detail. So you've got a patient with kind of COVID ARDS in essence. And as you'll note, we know and we remember from the pandemic, the ongoing pandemic, that you need to be careful with ARDS patients. They're in an acute inflammatory situation, if you like, and so prone to damage to the lungs, for not being too basic, but in essence that's what we're concerned about. But as you'll note here, physiotherapy intervention didn't start until day 10 and then day 12. So actually, are they slightly further into that inflammatory process? So hopefully the risk is slightly less. But then looking at the treatments that was completed, first of all, we've got the pressure settings. We've got an asymmetrical pressure setting, so hopefully enhancing that expiratory flow bias. We've got 15 litres of oxygen in train, so it's showing that that's possible. We've got repeated insufflations to exsufflation, so 3 insufflation breaths to 1 exsufflation, repeated a few times. And then they did some expiratory vibrations during the passive expirations, and then thoracic manually assisted cough with a parallel suction on the exsufflation breath. So it's really looking at what they've been doing. So you've got asymmetrical pressure setups, you've got expiratory vibs that also enhance expiratory flow, a thoracic manually assisted cough, which hopefully will enhance the cough effectiveness. And we know that from some of the neuromuscular literature that actually when you're combining multiple treatments, you do get an increased enhancement in your peak cough flow. Interestingly, the authors have also commented that it took 3 physiotherapists or 3 clinicians to treat this patient. And that again is really important. Implementing MIE in this patient group on ICU is more than a device. You need to think about how many clinicians you need to safely and effectively implement it also. So moving on to their session 2 treatment, which again is a couple of days later. And this again is interesting because there's almost some pre-MIE preparation of the treatment of the patient, if you like. So first of all, the patient had a hypertonic saline neb, oxygen was increased slightly, some closed suction, some expiratory vibrations. So it's almost as if they're clearing everything in the upper chest to then start their MIE treatment. So it's preparation of the patient. Even if you know there's phlegm here, don't start doing positive pressure insufflation breaths that you know is going to further embed it. You've then got the MIE setup, again an asymmetrical pressure setting, slightly lower oxygen that's been entrained, and then similar treatment to before. And interestingly, it wasn't quite clearing as much as they wanted, so they tweaked the pressures. So that's important. They're constant reassessment, constant adaptation of the treatment prescription to then get the results that you want. So again, this is a lovely example of using this treatment strategy in a really sick population. You've got a COVID ARDS patient who's also being prone, and we'll come back to that later on. So, I mean, I could go through loads of studies, but we don't need to go through all of them. But there's obviously a building amount of evidence, especially for using the device on our ICU, to say that, yeah, it's effective. We seem to be getting the outcomes that we want, but is it actually safe? So the scoping review that we finished last year, of the 28 citations, 20 studies, 13 of the 20 full studies addressed adverse events. And when I say addressed, I mean they mentioned the words adverse events. But then only 3 reported the occurrence of adverse events. So that's quite promising. You can see the lists there of things that were commented on. But actually, we still can't say whether it's a cause and effect relationship between the adverse event and the MIE. There was a lot going on. They're all on positive pressure ventilation for a start. They're all critically unwell. Most of them were in multi-organ failure. So these things are happening, but we can't definitely say that it's just due to mechanical insufflation, exsufflation. This is a useful study from 2018, the Sanchez-Garcia paper. This looked again at the use of MIE in intubated population to look at the safety. That was its primary outcome. So just 13 patients, and they looked at 26 different sessions, and they looked at different measures pre-MIE and then 5 and 60 minutes afterwards. The MIE setup was slightly higher pressures to what we've seen before, so plus 50, minus 45, and they planned to do up to 10 to 12 cycles, and they had 8 litres of oxygen entrained. What they actually found was that they, on average, did around 2 cycles, so nowhere near what they were planning, and they concluded that it was safe. There was no adverse events reported. However, when you carry on reading the discussion part, they do focus on two specific interactions. One where a patient had some ICP changes, but nothing that they would class as dangerous or enough to stop them. They just had lots of rests in between sessions and lowered the pressure slightly. And then another patient who had a bronchopleural fistula, so they actually reduced the pressures before they even started. So the pressures used were lower than the protocol, but it resulted in no adverse effects. So another study showing potentially this device could be safe in this patient group. So we also have a range of bench studies to look at, and these are again really interesting because it sounds awful, but they almost take the patient out of it, which sometimes can be really useful when you're trying to work out from a physiology perspective what the device is doing and therefore what the impact could be and what's being delivered to the patient. So most of the time the bench studies are looking at how the device is set up and the resulting impact on different flow rates generated, different volumes generated. So the ones I want to go through first of all is this Gurin paper from 2011, and in essence this paper just looked at the impact of an artificial airway, so an ET tube or a tracheostomy tube, on the resultant flows. They had a test lung at the end of the setup, which they changed the compliance and resistance for. And then for the MIE setup, they had a varying amount of different pressures that they worked through. And in essence, the conclusion was that as the tubes get narrower, your resultant peak expiratory flow rate was lower. It makes sense. As your tube narrows, we know that then there will be an increased resistance to airflow. Resistance to airflow is inversely proportional to the radius reduction, and that's really important. So again, they concluded that you would probably need to therefore increase the pressures that you're using if you're using MIE with an artificial airway. Useful. This paper that came out last year almost builds on that paper. So this is again looking at the impact of an interface, and the interface being either an ET tube or a face mask, and looks at the impact on the expiratory flow rates generated. So this study was done in just 12 patients, and they were a mix of ARDS or thoracic surgery patients. And they were split into two groups. So they had mechanical insufflation for 2 days via an ET tube, whilst they were obviously intubated and ventilated, and then for 24 hours after their extubation via a face mask. So those are the two interfaces. And they'd have two different treatment setups. So either just static pressures, so +40, -40, or incremental pressures building up from +30, -30, all the way up to +50, -50. And they'd have both of those twice a day, but just the order would switch around. So quite an interesting setup. In that bottom right hand corner there, I've just taken the picture of the setup just to show that actually it's really quite simple. That's a setup that will look really familiar to you. The only addition is the flow meter. That's it. So it shows that it shouldn't be too difficult for us to start looking at extra things like this. So moving on to their results, that top table, so table 2, shows that your expiratory flow rates in general are much reduced through an endotracheal tube in comparison to the face mask. You can see there that the peak expiratory flows range from -2.8 through to -2.96, whereas the face mask, they start with -2.66 and go up to -3.36. So that's quite important, that at all pressure settings, the resultant peak expiratory flow is lower through an ETT versus a face mask. So when we're treating the same patient, tubed and then post-extubation, are we tweaking our pressures or are we just pressing go? And that's something that we should be thinking about. If we then look at the second graph, so figure 3 at the bottom, this shows here that really in essence a faster peak expiratory flow is generated with those larger pressure gradients. So obviously the bigger pressure gradients being +50, -50, there's much bigger swings there. And again, that dotted line is that -2.70 cutoff that we're all aware of for kind of something being effective. So again, authors conclude that if you're going to use MIE through an ETT, you probably need to be increasing the pressures, and they were recommending +50, -50. And again, in these patients, yes, just 12 patients, but they decided that also it was a safe treatment technique to be using. They had no reported adverse events. So again, really positive results there. So with all this evidence that's kind of gradually building over a period of, like the last 10 years, really, are people actually now using MIE? Well, we completed this survey a few years ago now, and this is just the use of MIE on UK critical care units. So we had 166 respondents, and this was great that it was from literally all over the UK, a really nice spread, and a spread of clinician bandings as well, so not just the senior therapists that have responded. So most respondents had access to MIE for their unit. Not all had their own device specifically for their unit, but they could get hold of one if they wanted. 53% of the respondents were using the device in an intubated population, which is great. But actually, in comparison, 99% of respondents were using it in an extubated population. So there's quite a discrepancy there. And then when we're looking at frequency of use, the most commonly reported frequency was either weekly or monthly. And I think that when you get to using something monthly, we need to query whether that's really true implementation of a device. I guess you can argue that the caseload hasn't arisen, and that's fine. Not everybody has 20, 30, 40 ICU beds, but still from a safety perspective, from a clinician confidence, is that frequent enough? So is this problem just in the UK? No, actually it's not. This is a lovely illustration from a Dutch survey by Wilimke Stilmer, who looked at ICU settings in Amsterdam. And of the 72 surveys that were sent out, she had an 85% response rate, which is really good. And as you can see from this heat map at the bottom, each square, each column represents one of the ICUs, and it's shown the intensity of use of different airway care interventions. And MIE is a little sparse, either never used or only used on indication. So almost there is quite a heterogeneity in either the intensity and or the combination of airway care interventions in Amsterdam, but that's that's probably in agreement to what we're finding in the UK as well, and I'm sure in other places too. So going back to the UK survey, we then asked about what is stopping or what is encouraging you to be using the device. But actually it tended to be barriers that were talked about, and barriers such as perceived competence and lack of confidence, an inability to practice with the device, so educational needs, but also things like culture, culture of the team, culture of the multidisciplinary team. So more recently, we followed up the survey with some clinician interviews. And clinician here actually means physiotherapists, but also doctors and nurses were included, because the survey was showing that some of these cultural barriers were very much a multidisciplinary team issue rather than just team physio. So that's why all three professions were included. So we've completed 31 interviews in total, which obviously has created a lot of data. But actually the themes that are coming out are really quite similar. So again, culture is a big impact and quite a barrier, but also an enabler, but mostly a barrier to using the device in an ICU setting. And a barrier in two ways. So either if you're in a physiotherapy team and the most senior clinician doesn't tend to be using it or isn't a fan, then actually the rest of the team rarely comes and uses it. Even if you've got newer clinicians who are experiencing the device rotating in or coming from a different trust, the culture still overrides that. Culture within the MDT also is perceived from a physio perspective. There is the perception that sometimes the medics aren't on board, and therefore that can limit the impact of using the device. But actually that wasn't a two-way issue. The doctors didn't kind of report that issue of culture at all. So whether that's actually more perceived from the physio's perspective, I don't know. There is definitely a hierarchy of treatments that is described. So almost if all else fails, we'll get the MIE out. So used in quite a reactive manner rather than anything proactive, which I think is something that we can look at. And again, these educational needs have come out, but educational needs across all professions, but slightly differing educational needs. So there is definitely an interest and an appetite from the doctors and the nurses to learn more about this device and understand, so they can almost work out where it fits in ICU. But also from the physiotherapist perspective, definitely wanting to understand the physiology to help with clinical reasoning, but that practical hands-on experience as well seems really invaluable and much wanted. So hopefully we'll finish that, writing that up, and it will come out next year at some point. So just going back to this scoping review, we really wanted to kind of map how MIE is used in this intubated, ventilated population. We thought that would be quite useful. So we managed to include 28 citations, and these were a mix of studies. So some are full papers and full trials, some were just abstracts and kind of conference abstracts, and some were just trial registration. So even that is a mixture. The general indications to choose MIE were the presence of secretions or the episodes of mucus plugging. And contraindications to rule patients out of papers very much relates to the use of positive pressure and the risks for impacts such as pneumothoraces. So what we found was quite interesting. The way that the device is being used varies dramatically. So the most common pressure setting was +40, -40. That's probably not surprising, but again, quite a range of pressures used. Timing and frequency, again, varying quite substantially. But actually there was a true lack of consistency in reporting. So some papers just said that MIE was used, full stop. Some said we used it with +40, -40, full stop. Some gave all of the settings that were useful. Also, the outcome measures that were used varied dramatically. So out of the 28 citations, there were 27 different outcome measures, which then makes comparison across papers really, really challenging. The three most common outcome measures were reintubation rates, wet sputum rate rather than sputum volume, and then also pulmonary mechanics. The QR code there is actually through to the Core Outcome Set website. So because of this variation in outcome measures used, we really think it's important to try and develop a core outcome set for airway clearance in this acutely ventilated population. So that will start, we've already started it, and the Delphi for that hopefully will come out before Christmas, but maybe into the new year. But that's just a link to the registration page. So our kind of conclusions were that there is little consistency in how MIE is currently used in the literature. And so actually it's really challenging to make best practice recommendations that are evidence-based at this time. So obviously in the UK, we have a document already, and I think the results from this scoping review have meant that we are in the situation where we are currently updating it. And I think to try and strengthen that, we will organise an expert roundtable, so we have like this expert consensus, and put it through some of our key stakeholders, and then publish it so then it's useful and it can be used by clinicians. Hopefully at a later stage we can maybe include the paediatric group in that also. So I think overall, I mean, to me that's all quite positive. There is definitely growing evidence for the use of MIE in an intubated population, but what I think we also need to consider is what we don't know. So we don't yet know whether protocolized MIE setup is better than an individual setting. I think I've always advocated that we should have individualized treatment setups. Each patient is so different, everybody's lungs are so different. But actually, when you think of a protocolized setup, most of the literature uses +40, -40, and they've had positive impact and effect. So why do we need to tweak it and change it? And also, if you're thinking of the barriers to using the device in ICU, some of them are the safety and the confidence of clinicians. So actually, if there's just one way of setting it up, is that going to help the implementation? I don't know, but it's worth thinking about. What we also don't know is whether we should be using it pre-extubation or post-extubation, or a combination of both to promote that extubation success. Most papers use it either before or before and after, and compare that to standard care. There aren't studies yet that compare, all treatment arms. So there's almost a treatment arm missing. And I think it's very clear from the scoping review that there aren't any qualitative studies telling us what patients think about this device. What are their experiences? Do they even remember it? There are papers, so the Vilenka Stilmer, she's about to publish some focus group work, but that's with clinicians, again, exploring the barriers. And then obviously we've got our interviews that will be published soon. But again, that's with clinicians. So there is certainly that gap with what patients know. So I think we will start our patient interviews probably maybe before Christmas, but going into the new year. But it's going to be one study. It's not enough. We need to be looking at that more. But how I'd like to finish today's session is thinking about, what is really happening to the patient's lungs. And I think this is the bit that is the crux of maybe why this device hasn't been further implemented as yet. So a lot of the papers so far are showing that we've got increased secretion clearance, improved chest x-rays of atelectasis resolution, and then increased oxygen saturations. And, that's good, isn't it? But what we don't know is if we've you can propose that we've recruited some lung, but we don't know where in the lung we've recruited. Have we just recruited something, or over-recruited something that's already open? And have we had any impact on those areas that are a little bit shut down? We also don't know what's happening from an inflammatory perspective, sodium perspective, etc. So that's really important. But when we're thinking about over-distension, is that any change in volume that we're getting, is that in agreement to what your lung compliance is saying? So is the change in lung compliance appropriate to the change in volume? Because actually, if your compliance is staying the same or reducing, then you're probably over-distending areas rather than opening up new areas of atelectasis. And I think that's something that we need to be thinking about, and therefore using the numbers that are generated on the ventilators. So are we working with these positive and negative pressures, working with protective lung ventilation in mind? That we all know that that's how we ventilate patients on ICU, but is this device working with that? We should be working around those 6 millilitres per kilogram of predicted body weight. Is that what we're doing with plus 50, minus 50, plus 40, minus 40? We don't actually know. If we think of these bench studies that we've gone through, the Huan paper talked about plus 50, minus 50. And almost if you're doing it in a patient with an ET tube, we need to be increasing those pressures to overcome the resistance to airflow. And, is that okay? What are the impacts of insufflation on creating an inflation pressure? Are we creating barotrauma? Are we over-distending those areas and therefore having volutrauma? And because of the changing the swings from positive to negative pressure, are we actually opening and closing repeatedly lung units and therefore causing atellect trauma as well? And from an exsufflation perspective, what is the impact of this negative pressure? We all talk about maintaining PEEP and maybe clamping tubes to disconnect. So yes, that's been important from a COVID perspective and aerosol generating procedures, but sometimes we clamp to try and maintain pressure within the circuit. But if then we're going to a negative pressure, in a way, what's the point of clamping? I mean, I think there is a point, but, we're just trying to think of the physiology here. So again, we need to think about the purpose of your PEEP is to keep those alveoli open at the end of expiration. You're trying to reduce that shunt and prevent that atellect trauma. So actually, are we making that worse from using the positive and the negative pressure swings, or could we set it up in a way that does it slightly more carefully? And what are the time constants of our lung units? It will vary across the whole lung, but when we're reinsufflating, is that something that we're thinking about? And obviously in that case study that I presented, the patient was an acute COVID ARDS patient, but they were also in prone position, and quite often prone's almost reserved for those sickest patients, isn't it? So actually, was it too soon to be using this kind of device in that patient? Or when we think of the benefits of prone and why we use that, we use it to improve VQ mismatching, again, to reduce that shunt and to recruit those posterior segments. If we've got a patient in this position, is it that actually they're now in the best position to get the most out of the MIE device and hopefully prevent that over distension in those at-risk lung units? I don't know, but that's something that we need to think about. So what's next? And I think for us, we are trying to use electrical impedance tomography to look at just this. So we're looking and starting to look at the impact of MIE on lung recruitment and also de-recruitment. So EIT provides images which illustrate the distribution of volume across the lung through a measure of impedance. So you have this belt that goes around your chest wall, as you can see from that middle picture, and it has 16 electrodes going all the way around. And there's then a current that's put through them in pairs, which then measures the impedance. And this does up to kind of 50 measurements per second. So there's an awful lot of data that goes into generating these beautiful pictures. But these pictures here are showing us the regional ventilation distribution, which is really helpful to when we're thinking about recruitment and which part of the lung is recruiting. But also we can look at end inspiratory and end expiratory lung volumes. So thinking of then into MIE, we can look at lung volumes before the patient comes off the vent onto the MIE device. We can look at the impact of repeated insufflations. We can then look at the impact of the negative pressure breath, and then we can look at the impact of hopefully re-recruiting afterwards before we go back on the ventilator. Now, we've done this before in healthy people, in CF patients and neuromuscular, so it really should be able to be possible in the ICU population. But what we found in those groups were that with those repeated insufflations, you did get almost breath by breath recruitment, which is really positive. That's what we're wanting. With a negative pressure breath, you obviously do get gross de-recruitment. And then almost after a few positive pressure breaths again, you are re-recruiting, but it takes usually around 5 to 6 breaths, more so in that neuromuscular group, to get back to any kind of baseline. So how that's going to be seen in an ICU population, we don't yet know, but that's what we're going to try and have a look at. So fingers crossed. So in summary, I definitely think there is emerging evidence for MIE use outside of a neuromuscular population, but we can use a lot of that evidence and a lot of the theories from years and years of work and start pulling it into these new groups. We do still have poor implementation rates in these newer groups, but actually it's because there are barriers to implementation. And when you're thinking of things like culture and education, these are all things that can be changed. So I think that we can probably improve implementation in the next few years. But I think, you know, the conclusion always is more research, please. But I think that is the thing. We do need to keep studying these new patient groups. You can't just pull the data from one patient group and apply it straight into another. But most importantly, when you are using these devices with these new groups, we just need to share experiences, and then that will help overcome many of the barriers. So before we head to questions, I just need to invite you to next month's BREAS monthly webinar series, which is monitoring of the patient during non-invasive ventilation. As always, this is on the last Thursday of the month, so the 24th of November. 1 till 2 Central European time, which if you're in the UK means that it's at 12 till 1. So I have an alarm set on my phone. It's the only way forward. So for this session, we have Annalisa Carlucci, who's a professor of pulmonology from Italy. So I'm sure that will be a fantastic session. So with that, I'd like to thank you very much for joining me, and I'm really happy to answer, or at least attempt to answer, any questions.
Thank you very much, Emma, for an amazing talk, and right on time. It's incredible. We have a number of questions here in the chat. First, there's 2 which I'm going to take together because both of them are about extubation of the patient. So first question is if MIE is your standard practice after extubation, and then a related question, whether you perform MIE prior to extubation.
So I think in the unit that I work, I think the device is being used more and more, for sure, and it is used both before extubation via an ETT, and it is used after extubation, most likely with a face mask. To be honest, we don't often use a mouthpiece in this group. I don't think it's useful. but I wouldn't say we routinely use it. We would, you need to look at your patient. You need to see if the patient needs that. Sometimes there's other techniques that we can use. You don't have to go and get the MIE device out. So the answer, it's not a great answer, but yes, we do use it. We don't just use it routinely. We use it when we think it is indicated and we think they're at risk of extubation failure for whatever reason. But I would say that our use is also increasing, which I think is probably similar to a number of centres across the UK.
Okay, thank you. A comment and a question, I think, which comes from many centres. Are doctors are scared about the pressures they see on the MIE device? How can I convince them? Probably that it's safe, I would say.
Yeah, absolutely. I mean, tea and cake always helps. But I think having a conversation with somebody is the most important thing, because and almost acknowledging, I think, what we don't know. So then it's a shared decision making. And, at the end of the day, the consultants are and do have overall responsibility. But as physiotherapists in the UK, we are autonomous practitioners. So we don't necessarily get told what to do, which I think is amazing. But it is having that conversation and going, okay, well, yes, actually, we are using slightly higher pressures, but the evidence so far is showing that even with quite high pressures, even some of them go up to +70, there aren't adverse effects that are being seen. There are sometimes some transient changes cardiovascular wise. So yes, if you've got somebody who's really cardiovascular unstable, you might think twice. But otherwise, I think it's just a conversation and just working it through and clinically reasoning and hearing their side of the story as well, because they may know something that you're not aware of. Okay, great. And one question always triggers more questions, right? Here in the chat again, do you know if people are routinely using pressures above those that are safe, for example, +70? So if that's often used up to +70, I guess. So are people using it above +70? Well, I think the question is above those that are safe, and okay. I assume that +70 is in this regard looked upon as unsafe. Yeah, maybe. Okay. I was going to say, you'll struggle to go that much higher because the devices don't go higher than that. But I think, to be honest, the safety studies, if you look at the studies that have used safety, they're not all just using +40, -40. Some of them have gone to 50 and one did go to 70 and they say that's safe. But I think that makes me a little bit nervous, if I'm honest, because of what we don't know. And I think, yes, you can put your hands on and go, oh, I've got lovely expansion, we've nailed it. But it's, to me, we don't know necessarily where that expansion is coming from and like the balance between over distension of areas that are already open and therefore damaged in your baby lungs. So for me, I would tend to bring it down a little bit. So yeah, does that answer your question, Carl? Sorry. Yeah, I do think so. Yes, absolutely. Okay, cool. we stay in the questions around the pressures. Yes. Another question, is there evidence on how pressures should be changed between endotracheal tubes and tracheostomy? Not necessarily. So there's the Gurin bench study that looked at ETT and trachees. And yes, the resultant flows were slightly different. But in essence, it's the fact that you've got a narrower tube rather than a patent airway. There isn't, as far as I'm aware, and sorry if I've missed it, but I'm not aware of a paper that's compared ETT to trachea. So I think what you've got to consider is quite often you would hope with a trachea you are likely to have a patient who is more awake, and therefore tolerability could be quite different in comparison to somebody who's sedated and you can kind of crack on. So with the tracheas, you've got the communication between the patient and yourself to really enhance device and patient interaction. But they might not feel comfortable. You need to then monitor the potential, not adverse effects, but how are they feeling afterwards? Are they feeling nauseous? Have they got pain? Are any of those things that we can manage? Is it just pain relief? Is it discussing the technique? So I think there's more than pressure to think about. Yeah. Yeah, interesting. Are there any groups of patients
that you use it preventatively, other than spinal cord injury patients?
I mean, anybody who's potentially at risk of extubation failure. If you've got somebody who is either maybe slow to wake and respond to sedation holds, but they're almost still, the doctors are like, we're going to extubate them at 10. You're like, hurrah. You'd maybe think, okay, actually, let's really try and clear them out before extubation, because you've got that tube and you can just be a bit more in control. But then you might think, okay, right, I'm actually going to use this device afterwards as well, just to try and keep on top of things to get them through that, the period of time, that 48 hours where they are most likely to fail their extubation, when they're still potentially a bit drowsy, they're going to get tired quickly, they're just kind of coming to, if you like. So it is those patients who are at risk, the increased sputum load, the fatigue, potentially like kidney injury, because they're going to be slower to flush through their sedation, so on and so forth. So yeah, that's what I'd be thinking of.
Okay. Can you use the MIE with sedated patients, and where do you connect it on an endotracheal tube? End of the tube or in the circuit?
So yes, you can use it when patients are on a vent and they've got an ETT or a trachea, and almost where the vent tubing connects to the ETT or trachea is where we disconnect, and we tend to keep the closed suction in situ. So then, excuse me, when you're doing, this is me obviously suctioning, when you're doing the MIE intervention, as you come to the last insufflation breath, we get that suction down. So as soon as you flip into the exsufflation pressure, the negative suction pressure goes on, and you're doing a parallel suction. So wherever that phlegm's come to, i.e., where your suction catheter can reach, you're most likely to catch it before it goes back down again. So yeah, that's where you disconnect it. So that UK document, as well as words, it has some really nice pictures of where to connect and disconnect. So hopefully that would be helpful.
While you mentioned the document, is that something which is available online, is a question, or where can they find it?
Well, in her wiseness, Rachel Moses decided to put it in a Dropbox, which once you put something in a Dropbox, it's quite hard to find. So I've got a version of it. So I'm happy to email it to whoever. That's really not a problem. But in a way, in the new year, we'll publish the new updated one, which is pretty much going to say the same, but almost the rationale and some of the almost the clinical reasoning linked to the evidence is going to be within it.
Okay, so people need to stay tuned for a little bit longer, and it'll get published.
Of course, yeah, but I can email stuff. It's not a top secret at all.
Okay, yeah, there's questions on the endotracheal tube now. Do you increase the cuff pressure in the tube or track during MIE?
My preference is, say from a trachea perspective, I would definitely always prefer to have the cuff inflated, because we want the pressures that we're delivering to go through the tube into the lungs. Otherwise, it's going to go all over the shop. So with an ETT, our guidance document says to make sure it's really, it is properly inflated. So it's always worth checking it. I don't often almost overinflate it, because your cuff pressure should be optimal for your patient anyway, just as part of standard like nursing care and MDT care. And I think you've got to be careful of increasing those pressures because of damage to the airway wall. And that is important, because if we've got an airway wall that then is irritable and potentially edematous because we keep inflating this cuff too high, when they're extubated, you've then potentially got a slightly more at-risk irritable airway, which will impact the use of MIE afterwards. So yes, optimize cuff pressure, but don't overinflate is my opinion. Yeah, but you'll be able to hear cuff leak if you've got it, and then you can mend it.
Yeah. How important do you think it is to clamp the endotracheal tube? I don't normally do this. Is there a specific point in the respiratory cycle that you attach the clamp?
So how important is it? I think depends if I mean, COVID has impacted that, and as much as I don't like, let's not open the aerosol generating procedure kind of worms, but during COVID it was super important because you're trying to prevent the dispersion of potentially infectious aerosols. So in that situation, I would say that it was absolutely essential. When it comes to a non-COVID patient, it's not essential. It's doable. I mean, we tend to use the manual disconnect on the ventilator to prevent the spraying, but as soon as you disconnect, you are losing the PEEP. So I think it would depend on what PEEP the patient's on, how dependent they are upon that PEEP. So if they're maybe towards the higher end, so kind of the 8, 10, maybe 12, and I would think about that carefully. It's useful to see what they do on the ventilator. Are they recruitable? So you could do like ventilator hyperinflation, except for example, to see if their lungs respond. Because then if you do just disconnect without clamping, when you're doing your insufflations, either one or repeated, if you're trying to recruit, you know you're probably going to have a nice positive impact from that. But at the same time, if they're really PEEP dependent and you're disconnecting, you could have a negative consequences of that. So the clamping prevents the loss of PEEP potentially, but you're still going to use negative pressure. So it's a total balance. Where you do it is here. It's just on the it's just on the end of the ETT. Obviously using clamp scissors, not real scissors, because that is not useful. But almost I would like to have a breath and then clamp, so you've got the best volume as you're clamping, because you'll still probably lose something. That's a very long answer, I'm sorry. It's not a straightforward answer though.
Yeah. Last question on the ETT, I think. But there's many other questions coming in, Emma. What is the impact of dead space in ETT, track, NIV interfaces when using MIE?
By NIV interfaces, I presume it's just a
or mask, probably, yes. ETT, track, or mask.
Well, I mean, to be honest, we probably don't truly know. Is the honest answer. I mean, it will have some impact, but not. I don't think it has a huge impact, because if you're using it through a tube, you're not adding your MIE tubing circuit to the ventilator tubing circuit. You're almost replacing like for like. So, and I think that dead space is there when they're on the ventilator. So we'll almost already know how the patient is. And so it's kind of the same. So I don't know if, maybe I should, but I don't know if I necessarily think specifically about that when I'm setting it up. I'm just going to make me think about it now. But no, I don't think it's too problematic.
Okay. How does the parallel suctioning, which you described, while exsufflation affect the exsufflation pressures?
I'm not aware that it does. The beauty of using this device is that you're exchanging MIE device for the ventilator. So when you sometimes suction otherwise, putting on the negative pressure, sometimes the vent recognises that and then can deliver a breath. So that's tricky, because you've just done all this hard work to start shifting phlegm, and then you go to press suck and actually the vent goes, oh, nearly, and then it pushes it away from you. So you don't have that with MIE. Carl, sorry, can you repeat the question for me?
Yes, if I can
sorry.
Find it again. No, that's no problem.
Keeping you on your toes.
Keeps me on my toes, as you say. Yes, how does parallel suctioning while exsufflation affects exsufflation pressures?
Yeah, I don't think it does. I mean, it might slightly, but in essence, you're sucking. Suction is a negative pressure. So you're almost negative to negative, which I know two negatives aren't necessarily negative, but I don't think of it like that. If you were to do your exsufflation breath and stop it and then do your suction, all the phlegm that you've cleared up to a point will have moved, and it only will have moved back into the lungs. So actually, again, all that hard work that you've done, manual technique, setting up the MIE device, will be lost.
Okay. Stay with me, longest question so far. Considering the complications, was de-recruitment mentioned? A concern with significant low pressure exsufflation would be causing or increasing de-recruitment or atelectasis. Size of tube would be a factor in this too, it seems. Recruitment breaths at the end of the treatment is used with other groups of patients. Would this be something that would be recommended in this population? End of question. So basically, I think it's about recruitment breaths. Yes.
Cool, blimey. So there aren't necessarily studies that have looked at it. I guess you can hypothesize that de-recruitment is occurring because sometimes there are transient changes to your oxygen saturations in a negative manner, but by the end of treatment, it's a positive change and they increase or they're the same. But from the EIT work that we've done, you do de-recruit, and even a healthy person de-recruits. You're sucking, minus 40 centimeters water out. You're definitely going to suck air out. So yes, I think you are going to de-recruit, and I would put a fair amount of money on that. Again, where you de-recruit is something to think about. Is it those areas that are already just totally inflated? And again, is it those areas that you've just worked really hard to start inflating, you've just shut them straight back down again? So for me, the reinsufflation breaths are really, really important. So then when you're leaving your patient, you're leaving them to rest and not recover. And there is a really important difference between the two. So obviously, for example, on the Clearway 1, they used to be able to program those 2 reinsufflation breaths. For me, that's not enough. So the beauty of Clearway 2, but also the 70, is that especially in the advanced auto mode of the 70, you can just start the cycle all over again and do those kind of pre-cough breaths. And for me, that's what we'd use as the reinsufflation. And again, on the Clearways, Clearway 2, you can set a good number of breaths. And I think it was between more like 5, 6 plus breaths that were required to really reinflate back to a baseline before insufflation pressures. So it is something that needs to be thought about, and it is something that needs to be done properly to get the most out of your treatment.
Okay, great. I know that we're running a bit over time, but I also see that many of you are still online, so I think we'll take some more questions. What is the evidence regarding the use of saline, hypertonic saline instillation prior to MIE?
In theory, there's no evidence, but actually there is. Now you said that, there is a paper, and I think it's a Martinez paper, that did use hypertonic saline, and I think they found that it did help. But I think what you need to think of is, has your patient got any form of cough? So if there's no cough reflex at all, sometimes it is a bit dodgy to add a load of saline, because how do you know you're truly going to get it back, especially if you're using repeated insufflations? Having said that, we there's no real evidence to saline use at all, but actually it works a treat sometimes. So, and I think the most recent suctioning guidelines again have mentioned the use of saline. I'm not sure they're overly keen on it, but again, people are using it. So don't just put it down routinely. Use it carefully, think it through to make sure that you are going to be clearing what you're putting in, otherwise you're going to make their chest worse. But at the same time, if you're going to use it, I would don't just put a mil down. That's not useful. You need to put a decent whack down for sure.
Mm-hmm.
That was a scientific measurement.
Same person is asking if the results from the SMASH trial have been published.
Not that I'm aware of. I don't. Not that I'm aware of. I know exactly who that question's come from. No.
Okay. You arranged that question up front. In your experience, is hypotension a problem with the high insufflation pressures in ICU? Hypo, yes.
Hypo. Yes and no, and I think this is tricky and it's a bit of a rubbish answer, but when you're using it, if blood pressure is going to be impacted, it either goes really, really high, seems really obvious, but really, really high, and that I think that quite often seems to be in the kind of cardiac arrest patients who have hypoxic brain injuries, or it's going really, really low. It doesn't seem to be otherwise it's just a transient change and it's okay. But you know, when you think of the physiology, it makes sense. You're putting in, you know, positive or negative pressure, which is going to impact on your venous return and your resultant cardiac output. So it's looking at your patient before you start. Are they cardiovascularly stable? Are they requiring inotropic support? And how have they responded to other interventions? What are they like when they're rolled, when they have mouth care, when they're suctioned? And it's going to give you an indication of whether they're going to enjoy your treatment session or not, and then they'll respond accordingly. But I think the hypertension is the bit that sometimes, I mean, don't get me wrong, I'd like everybody to have a decent blood pressure. I'm not being flippant about hypotensive, but it's the hypertension that does make me really nervous, because, you know, that's could have quite catastrophic impact on resultant brain injury. And again, I think we really need to think about that. Yeah.
Okay. From your previous work, were you able to identify how many physios use MIE in prone patients?
No, we didn't ask that in our survey. I think before COVID, it was probably quite rare, if I'm honest, because almost proning is reserved for, you know, for that really sick cohort. That's why we use it. But I think with COVID, we saw again, and we were reminded of how beneficial proning can be. Plus, added on to the fact that because everybody needed proning, it was just a constant round robin of flipping people onto their tummies, onto their backs for a short period. So I think, in a way, from an airway clearance perspective, once we had acknowledged that there really was phlegm down there, that these patients did have physio requirements from a UK perspective. I know other countries are different, but we had no choice but to treat them in prone, because if we were waiting for everybody to be resupined, we'd have never seen any patients. So I think we were almost cornered a little bit and had no choice but to do it in that position, and actually found some really beneficial effects. So, and you know, as that case study illustrates from Tommy's. So I think that it's something we shouldn't rule out. But again, we need to be cautious because those patients are sick.
Yeah, sure. In the research papers, is there a reason that exsufflation pressure isn't more negative in order to emphasize the expiratory flow bias?
No, I think that the Gonzalez paper started with +40, -40, and I think many papers have then built on that, because then you've got the comparison contrast across studies, and then more recent papers have started to tweak them because of the results from the bench studies. So no, they've got a symmetrical setup, but it's not just about the pressure. You know, we know from the neuromuscular population, so in the self-ventilating group, that slowing that insufflation pressure down is really, really important, and that almost tweaking that insufflation actually has a change to the exsufflation of the expiratory flow rates that are generated, which initially seems a bit backwards, but that is how the physiology works. So as long as you're then manipulating around that, so maybe your flow rate has come right down, your insufflation time is a bit longer, then you can overcome it and still have an expiratory flow bias.
Great, thank you. Would you look at MHI prior to MIE, or is it patient dependent?
I don't personally use MHI before, but it doesn't mean it can't be done. I mean, again, if you go back to the Thomas case study, I can't remember if they used MHI beforehand, sorry, but in essence, they almost prepped the patient first, and that they cleared what was up here, is my understanding of when I was reading it, and then they started MIE to try and catch the phlegm that was further down. So actually, if that's what you're clinically reasoning to be effective, then that's great. But if you're going to use MIE anyway, you're going to definitely get better expiratory flows with MIE versus MHI because you've got a negative pressure exflation, and on the MHR you have just got that quick release. As satisfying as that sound is, it does not generate the same flow rates.
People with interest around the combination of the MIE and the ventilator, do you think that peak airway pressure or compliance on the ventilator can help with what pressures to use?
Yes. I think looking at your compliance is really important, because if you're, and which is why I think sometimes it is really helpful to return to the ventilator in between cycles rather than just doing some tidal volume breaths, because if your compliance isn't changing as you'd predict, and it's staying the same or even it's lowering, then you are most likely to be getting over distension rather than like true recruitment, if that makes sense. So if you've got a lovely set of compliant lungs, which is possibly not that likely on ICU, really, I would be quite careful. I wouldn't just slam a load of pressure in. I would think more about tweaking the flows to slow that breath in and maybe gradually increasing it. But you've also got to think of your time constants of your lung units, which you could calculate. I mean, let's not go into that now. That's a whole lecture in itself, but you can work out your time constants, and then you need kind of like your 75%, etc. of it. So there is a lot to think about, but yes, a ventilator is the most sophisticated computer you will ever get, and it gives us a lot of information, and I really think we should use the numbers to help us. So yes, I would look at resistance, compliance, and just have a think about how they've responded to other treatments, which is why I think sometimes checking the recruitment ability through the vent, like VHI or something, is really useful.
Well, that nicely brings us to the next question. Do you measure peak expiratory flow on the ventilator and use that as indicator for the need of MIE?
I mean, you can do. If you get a cough, you can pause the vent waveforms and then just scroll across and have a look at it. The likelihood, if you've got a patient on a ventilator, is that their cough is impacted. I mean, they're going to be weak. Their glottis is held open by the artificial airway. It's hard. And don't be fooled in, like, I mean, maybe we shouldn't get into the head injuries, but you know, like those head injury patients who have the most violent of coughs, and you think, whoa, that's amazing. But actually, is it still actually effective? It's not always. So the likelihood is that their cough is going to be a bit rubbish. So I don't just go on the peak cough flow values for sure. And actually the peak cough flow value critical thresholds that we have were done in self-ventilating patients, not in tubed patients. So you can't just change them across, and you can't just change them between ETT and trachea either.
Yeah, there's a follow-up question on the previous one from the same person. If you would look at peak airway pressures to look or to guide you on your positive inspiratory pressure during MIE.
Do I?
If that could be an idea.
Well, yeah. I mean, yeah, absolutely. Again, it goes back to protective lung ventilation and thinking about what your peak pressures are, what your plateau pressures are, and then thinking, you know, proper physiology here. What are all your transpulmonary pressures? What's the driving pressure of the patient? You know, all of these things, they are all really important to think about, which is why, as much as I am very pro this device in the ICU population, and I do really think it has a place, but I think that the application of it needs to be quite careful, and it just comes down to the physiology. So I think whoever the questions come from, I think it's a very sensible idea, because you know that is the crux of it. We don't want to cause more damage. So yes, is my short answer.
That's a short answer. Okay, thank you very much again, all of you still online. I was about to say that we came to the last question, but as we speak, there's another question that comes in. So I hope you still have another minute or two. Can you perform MIE on patients who are paralyzed?
Yeah.
For example, on atracurium.
Absolutely. And in a way, it's possibly the easiest situation to do it in, because you haven't got, it sounds awful, but you haven't got, I don't know how to word this without sounding awful, but you haven't got the patient's not going to be interacting with the device. It's going to be the physiology of the patient that is. So actually, because you haven't got the patient effort, etc., it makes it really quite easy. We are just totally in control. And it can work really, really nicely. How else are you going to really get a good cough? You can obviously use manually assisted cough and stuff too, but yes, definitely.
Loud and clear. So now we are at the last question of the day. With regards to culture of the unit and use, do you think or find that there is more MIE use in units with ring-fenced therapy provision as opposed to those without?
Yeah, absolutely, because you've got
maybe Emma, what is ring-fenced therapy provision? Because that honestly is a term I'm not familiar with here in Belgium.
Okay, so ring-fenced, I guess, is it's this. So it means that those clinicians are planned and put in place just for doing their treatments within a specific area. Okay. Yeah, I think that's an okay example. That's come from above me.
Dedicated staff.
That's a much more eloquent way of putting it. Yes, Carl. So, brilliant. So yeah, I think it does help if you have ring fence staff, for sure. And I think because they understand the patient group, they're there all the time. So you also have those MDT interactions, and you've got the same group of clinicians trying it with different patients. So they've also got almost like the patients behind them as well, the hands-on experience. And I think that makes such a big impact. The problem we've got is where you've got there is a hierarchy, and unfortunately if the top people at the top aren't keen and proactive with it, that has a negative knock on. So that's something that we really need to try and overcome, because I think no matter how many years you've got under your belt and how many patients you've seen, you know, some of our newer clinicians are rotating from different areas, from different hospitals, and we can still learn so much from them. So, you know, we've got patients are changing, they're getting sicker and they're getting more complex. So we need to think about that.
Okay, thank you very much. Thank you, Emma, first of all, for this amazing presentation. You have guided us through the literature, and then in the Q&A section, we could benefit from all your experience and your knowledge. So thank you for sharing all that with us.